Hello, in this video, we will be discussing about galactosemia, and the core concept and core discussion will be based on pathophysiology and also the genetic basis of galactosemia. So what is galactose? Galactose is an aldose exhaust sugar. It's a C4 epimer of glucose. The main source of galactose is milk and dairy-based products, as we all know. Even though we completely restrict galactose or for that matter lactose in our diet, there will still be production of galactose by endogenous mechanism in our body. That's one of the reasons why, despite having a very strict adherence to galactose restricted diet, there can still be manifestations of galactosemia in galactosemia patients. Galactose is a source of energy. However, the main purpose of galactose in our body is to make glycolipids, glycoproteins, etc., which are core components of cell surface receptors, extracellular matrix, and myelin sheath. Coming to galactose metabolism in our body, galactose is obtained from lactose. Lactose contains glucose as well as galactose. So when lactose is broken down by lactase in the intestine, it forms one molecule of glucose and galactose each. This glucose and galactose is taken into bloodstream by SGLT1 transporter. Once it reaches bloodstream, it is taken into liver by GLUT2 transporter. Once it enters the liver, there is a series of reactions through which UDP galactose, UDP glucose, etc. are produced. The UDP glucose can go into glycogen synthesis. UDP glucose 1-phosphate can go into glycolysis and other subsequent processes to generate energy. However, in this class, we will be concentrating more on the Lilloir pathway, that is this. The initial 3 to 4 steps, which are crucial as far as understanding the pathophysiology of galactosemia is concerned. So what happens? Lactose is broken down into glucose as well as galactose. The galactose will be in beta D form. It is converted to alpha D form by an enzyme called galactose beta-rotase. Second step is alpha D galactose is converted to galactose 1-phosphate, which is mediated by the enzyme called galactokinase. There are two more possible conversions of alpha D galactose is possible. One is to galactonate by galactose dehydrogenase, and other one is to Galactitol by aldose reductase. Usually, these two pathways are less active, provided galactokinase is present in sufficient amount. Once galactose 1-phosphate is formed, it is converted to UDP-Gal by the enzyme called galactose 1-phosphate uridyl transferase, which is also called GALT. GALT is one of the key enzymes, the deficiency of which can cause galactosemia, the classical form of galactosemia, and we will be discussing about this in detail in the subsequent slides. There is one alternate pathway in which galactose 1-phosphate can be converted to UDP-Gal, which is mediated by UDP glucose galactose pyrophosphorylase. However, suppose there is a deficiency of GALT, then this pyrophosphorylase cannot completely compensate this deficiency of GALT, which means there will be accumulation of galactose 1-phosphate. That's why if there is deficiency of GALT enzyme, there will be manifestations of galactosemia, even though there is an alternate pathway possible using pyrophosphorylase, because pyrophosphorylase is not as good as UDP transferase of galactose 1-phosphate as far as converting to UDP-Gal is concerned. This UDP-Gal, that is UDP-galactose, is crucial for an array of functions like formation of glycoproteins, glycolipids, myelin sheath, etc. Then the last enzyme, the fourth enzyme, is called UDP-Gal epimerase. Epimerase is important for the interconversion of UDP galactose into UDP glucose. and also N-acetyl UDP glucosamine to N-acetyl UDP galactosamine. All these UDP compounds are important for the formation of extracellular matrix, glycoprotein, glycolipids, cell surface receptors, myelin sheath, etc. These four are the key enzymes required in the Lilloir pathway. So the deficiency of each one of them can cause galactosemia in one way or the other, and we will be discussing in detail. What are the possibilities that we need to consider when we get a raised galactose in serum? The most common one is galactosemia, that is disruptions in various steps of galactose metabolism. Second one is portosystemic shunts. This is because suppose there is a portosystemic shunt. That means the blood will bypass the liver and will reach to systemic circulation from portal circulation. Those conditions need to be considered when there is elevated galactose and provided the liver function is as such okay. There can be impairment of liver function, like any conditions which cause cholestasis. And there can be metabolic disorders such as Fanconi-Bickel syndrome, which is actually the disorder of GLUT2 transporter. Coming to the inborn errors of metabolism associated with galactose metabolism. The first one is galactose kinase deficiency. Second one is the transferase deficiency. Third one is the epimerase deficiency. Fourth one is the mutarotatase deficiency. Fifth one is the SGLT1 deficiency, which is necessary for the absorption from intestine to bloodstream. Last one is the Fanconi-Bickel syndrome, which is due to the deficiency of GLUT2 transporter. Coming to GALT deficiency, which is also called the classical form of galactosemia. So what happens in GALT deficiency? There will be a deficiency this step of the Lilloir pathway. There won't be conversion of galactose 1-phosphate to UDP galactose. Because of which, what will happen? The main pathophysiology is due to the accumulation of galactose 1-phosphate and galactose because the forward steps are not happening properly. Also, there is deficiency of UDP galactose. So there is deficiency of UDP galactose as well as accumulation of other substrates. So galactose 1-phosphate is very toxic to practically all tissues of the body, mainly to brain, liver, kidney, ovaries. If galactose is accumulated and these forward steps are not happening, then it will go to these alternate pathways. Usually aldose reductase don't act on galactose. It is mainly for the conversion of glucose to fructose. However, if galactose are in high concentration, it will lead to the formation of increased levels of galactitol. Also, galactose dehydrogenase will act on excess galactose to form excess galactonate, and there will be increased galactose 1-phosphate. The onset will be in the infancy itself, because once we initiate feeding, breast will contain lactose. Lactose will be converted to galactose. Galactose accumulation will form galactosemic manifestations. There will be involvement of liver, kidneys, and brain. So there will be altered liver function. There will be vomiting, lethargy, bleeding manifestations, jaundice. There will be generalized aminoaciduria due to renal involvement. There can be seizures. Usually, the galactosemia kids can have E. coli sepsis, or for that matter, multiple gram-negative organisms can cause sepsis in galactosemia. That is because galactose in excess level is a free radical scavenger. The hydroxyl ions, which are required for the bacterial cell killing in polymorpho-neutrophil cells, are scavenged by excess galactose. So there will be impaired bactericidal activity of polymorpho-neutrophils, which can result in impaired immunity, which can predispose to bacterial infections. Then there can be metabolic acidosis, renal tubular acidosis, galactosuria, glycosuria, aminoaciduria, and the erythrocyte galactose 1-phosphate levels will be more than 10 because the forward pathways, forward reactions are not happening in place. Even though the cutoff is more than 10, it will be usually in the range of hundreds. Usually it will be near 120. Also remember, if you see the tissues which are involved in galactosemia, those are the tissues in which there is high GALT mRNA activity, which means galactose metabolism is very active in those tissues. And if you see the green box, skeletal muscle and testes have the least GALT mRNA levels and enzyme activity. That's why these two tissues are very less affected in galactosemia. The implications: galactose 1 phosphate and galactitol can cause cerebral, renal, and hepatic manifestations, which I already described. Galactitol and galactonate can cause cataract. Defective galactosylation of sphingolipids due to low UDP GAL can cause neurological sequelae. I already told UDP galactose is important for myelination and formation of various glycoproteins. If that is not there, then there will be chronic long-term neurological sequelae in the form of development delay, ataxia, tremor, dystonia, etc. A quick word about galactitol. Galactitol is a glucose enzyme produced by aldose reductase. Usually, aldose reductase is there for conversion of excess glucose to fructose. However, in excess amount of galactose, then this enzyme will act on galactose as well, resulting in formation of galactitol. Galactitol causes intracellular accumulation in lens, which is osmotically active, and there will be formation of cataract. And if it accumulates in neurons, it can cause pseudotumor cerebri also. So there are three variants of GALT deficiency. One is the classical galactosemia, which we always describe as a very sick child in the newborn period with liver and kidney function impairment. That is classical galactosemia. When the enzyme activity is less than 1%, there is a clinical variant in which the enzyme activity will be less than 15%. The symptoms won't be as severe as galactosemia, classical galactosemia. However, the child can still land up in hepatic involvement, renal involvement in the newborn period itself. I will describe in detail in the coming slides. And there's a biochemical variant called Duarte variant, in which there will be newborn screening for galactosemia will be positive. However, the child won't be having any clinical manifestations. I will describe that too in detail. Coming to GALT deficiency, the clinical variant. I have already described the classical variant of galactosemia in the previous slides, the one with maximum severity. In clinical variant, the GALT enzyme activity will be between 1 to 15%, usually 1 to 10%. So what happens is that in the initial days of life, usually the newborn screening will happen. At that time, the levels of galactose won't be as high as in the classical galactosemia to be picked by newborn screening. So these children may have a chance that they will be missed in the newborn screening for galactosemia. However, the GALT enzyme is not too high in their body. So what will happen? They can still present as classical galactosemia, even though the onset may be slightly later. This is actually a catastrophic event because we are doing newborn screening, but a part of this clinical variant can be missed in newborn screening, and they will land up in crisis after a few days. Usually, the erythrocyte galactose 1 phosphate is more than 10, and once we initiate treatment, the levels will be less than 10, which is in the normal range. Which is against the findings seen in classical galactosemia. In classical galactosemia, this erythrocyte galactose 1 phosphate, despite having strict adherence, the levels will be will be more than 1, will be between 3 to 5. However, in clinical variant, it will reach the normal level. That is because there is a small amount of residual activity of GALT enzyme. And these children usually don't have long-term neurological complications or primary of ovarian insufficiency. Coming to the Duarte variant, also called biochemical variant. In this, what happens is that there is a genetic variation because of which there will be decreased activity of GALT enzyme. However, the enzyme activity will be minimum 25%. So there won't be any significant clinical manifestation. The child will be living a normal life and will have a normal quality of life as well. However, some of these kids will present as newborn screen positive for galactosemia, because in some kids there will be slightly elevated levels of galactose in the newborn period. However, when we do the confirmatory test, that is GALT enzyme assay, we will get an enzyme activity of around 25 to 50 to 75%. So that is called Duarte variant. It doesn't have any clinical significance as such. So what happens is that in some kids, there will be one allele with a pathogenic variant of galactosemia. However, on the second allele, there will be a Duarte allele, D2 allele. So the pathogenic allele will definitely cause a decreased activity of GALT enzyme. However, Duarte allele, the D2 allele, won't affect the activity that much. So instead of having a severe classical galactosemia, they will be having a clinically irrelevant enzyme deficiency. The child will be asymptomatic. However, newborn screening can be positive. In fact, Duarte variants form the majority of cases of false positive galactosemia screens in newborn period. So what happens in Duarte variant? What is that Duarte allele? The Duarte allele means there will be a 4 base pair deletion in the promoter region of that gene. So because of which there will be impaired transcription to mRNA. So there will be decreased mRNA levels. However, it won't be very severe. So when do we get a Duarte variant in patients? So there are two possibilities. One is the patient is homozygous for this D2 allele. That is, both the alleles will be harboring D2 variant, or one allele will be having a pathogenic, the classical form galactosemia variant. Second allele will be having a D2 variant. So homozygous combination, or one allele with classical galactosemia variant, second allele with D2 variant. So these two combinations are possible. These children will be clinically normal. So these are the various variants associated with galactosemia. The classical galactosemia variants are, one is Q188R, that is, there is amino acid change from glutamate to arginine in 8188 position. These variants are usually seen among Caucasian population. The usual classic galactosemia, the most severe one, is related to this genetic variation. The second one, the clinical variant galactosemia, is more commonly seen in African American population, in which there will be some activity of GALT enzyme. However, they can still land up in crisis. However, if treatment is properly initiated, the long-term outcome will be good for this patient. In classical galactosemia, if we initiate diet at the right time, the clinical outcome will be better, but they can still have long-term neurological outcome or ovarian dysfunction. This is the biochemical variant, also called Duarte variant. Coming to diagnostic investigations, what all investigation do we need in galactosemia? We have to do LFT, RFT, liver functional renal function, and urine non-reducing substance. Remember, urine non-glucose reducing substance, that is, we are targeting galactose, it can become negative once we start IV fluids. When we admit a child in crisis suspecting galactosemia, we will keep the child NPO, that is nil per oral, because the child may be in shock or metabolic crisis. At that time, since we are giving glucose through IV fluids, galactose levels can come down rapidly, and urine non-glucose reducing substance can come as negative. In that case, GALT enzyme activity, that is done from freshly drawn erythrocytes, can give us a clue. Ideally, we need to send 1 ml of heparin, blood in heparin vial, that is a green one, and then we can check for GALT enzyme. Blood transfusion is given for the child and we still want to make a diagnosis. Then measurement of urinary galactitol or genetic testing, that is, we can go for variant testing or whole exome sequencing and find out a little bit about the treatment of galactosemia. So what are the core concepts regarding the treatment of galactosemia? So the best treatment is restriction of galactose. How to restrict the galactose? Then we have to start soya-based or elemental formula, which is deficient of galactose. And so what is the disadvantage is that means we have to withhold breast milk, because breast milk contains lactose. This elemental formula may not always contain all the nutrients required for the normal growth. So we may have to supplement multivitamins, calcium, vitamin D, etc. However, once we start the formula, the cataract will definitely improve, jaundice will resolve, cirrhosis can be prevented, and renal function tests will be normalized. So what happens? There's an enzyme block here. So we are preventing galactose here. So galactose 1 phosphate will not be formed or will be less formed, because of which the toxic effects of galactosemia can be prevented. However, we cannot prevent everything, because endogenous galactose metabolism will be happening still. So because of which there will be some manifestations of galactosemia, usually which will affect the long-term outcome. That is the neurological manifestation, which include language delay, cognitive delay, dystonia, tremor, ataxia, etc., which will present after a few years. So, is there a role of restricting lactose in pregnancy to avoid possible galactosemia? For example, the first child had galactosemia. Parents are apprehensive, the next child will also be having galactosemia or not. In that case, they restricted lactose during pregnancy. This won't be having any effect on the treatment of galactosemia, because as far as from the available literature, what is found out that there is no difference between the outcome in galactosemia if mother is on a restricted galactose diet during pregnancy or not. Treatment also involves ophthalmological examination, because there's a chance of cataract. And remember, the cataract of galactosemia, if it is not dense, if it is in the initial stage, can be reversed by dietary management. However, if it goes untreated or improperly treated, then it will become dense. Then we need to go for the surgical management. Early stimulation for language and cognitive delay is very important, because they can still have cognitive decline due to deficiency of UDP galactose necessary for the formation of myelin sheath, etc. And we need to annually evaluate for neurological symptoms like dystonia, ataxia, tremors, etc. Due to some unknown mechanism, there is decreased bone mineral density from age 8 to 10 years. So we may need to consider calcium and vitamin D supplementation. The reason is not yet very clear. Once the child grows, how do we manage the diet? We have to restrict milk-based diet, definitely. However, galactose is also present in vegetables like legumes and some fruits also. Do we need to restrict that? The answer is no, because from the literature, scientists have compared the outcomes in children who are on very strict diet, completely lactose restricted diet, in which they avoid legumes, fruits, and some fruits and vegetables also, and they compared the outcome in children who are on only dairy restricted diet, that is milk restricted diet. The outcomes have been long-term outcomes have been comparable in both the groups. So we don't need to avoid vegetables, and any diet in which the average concentration of galactose is 25 less than 25 mg per 100 gram of that diet can be consumed. That is, any diet which is less in galactose, a minimal level of galactose is okay for the body. Cheese and yogurt can be taken. Coming to the fertility and pregnancy part, the galactose metabolism happens a lot in ovary. I have already explained on the previous slide. And it was found that galactosemia patients have hypergonadotrophic hypogonadism, that is primary ovarian insufficiency. 1/3 of these classical galactosemia patients may not achieve spontaneous menarche, that is 2/3 achieve spontaneous menarche. Even when those patients who achieve spontaneous menarche, they will have spontaneous cessation of menses within 5 years. This is not seen in clinical variant of galactosemia as well as in the Duarte variant. So only the most severe version of galactosemia, that is classical galactosemia with less than 1% of enzyme activity, will be having this complication. And scientists found out that there is diminished number of ovarian follicles by 6 months of age in the classical galactosemia affected females. So they concluded that the insult is happening in utero as well. And on top of that, there is one more problem. The hormonal therapy given to these ladies for attainment of menarche and continuation of menses, those hormonal drugs also contains lactose as a filler, which can cause counterproductive effects. So why there is primary ovarian insufficiency in galactosemia? There are 4 mechanisms. One is galactose 1-phosphate and galactose. These two are toxic substances in higher concentration. This can directly cause apoptosis of oocytes. Second one is there is deficiency of UDP galactose. So UDP gal is necessary for the formation of glycoprotein, glycolipids, membrane surface receptors, and also myelin sheath. So all these cell surface receptors, glycoproteins, all are important for the growth of oocytes, in the absence of which there can be cell death. Third one is if there is decrease in the levels of GALT enzyme, there will be defective glycosylation of FSH molecule. So defective glycosylation will result in impaired downstream process of FSH binding, resulting in poor activation of the ovarian follicles. The fourth one is related to epigenetic mechanisms, which is beyond the scope of this lecture. So I have completely covered GALT deficiency. Coming to epimerase deficiency. So epimerase deficiency, what happens in epimerase deficiency is that there are 3 forms. One is peripheral form, one is intermediate form, one is generalized form. Peripheral form constitutes those cases in which there is deficiency of enzyme only in RBCs or WBCs. Liver will be having normal enzyme levels, kidneys will be having normal enzyme level, so there won't be any systemic manifestations. These children usually remain asymptomatic and they will be having a normal lifespan. In intermediate form, there will be deficiency in the RBC as well as WBC. However, 50% of enzyme activity will be present in all the tissues. Even 50% is good enough to avoid liver and kidney complications. So again, these people will also remain asymptomatic. However, the rarest one among epimerase deficiency, that is the generalized epimerase deficiency, they will be having low activity in all the tissues. So they manifest just like classical galactosemia. However, they will be having some additional features like hypotonia, sensory neural hearing loss, thrombocytopenia, lymphopenia, and skeletal deformities. Skeletal deformities include microglia, flexion deformities of fingers, and hip dysplasia. The reasons are not well established for these extra manifestations. So coming back to pathway again, this is the step in which there is enzyme deficiency. So there will be impaired formation of these intermediates, N-acetyl, UDP, glucosamine, and galactosamine. And as a result of this enzyme deficiency, there will be increased production of all these metabolites. So there will be increase in galactose 1-phosphate and galactose, which are toxic in higher levels, which can cause array of systemic manifestations. Coming to investigations and treatment of epimerase deficiency, there will be increased galactose levels, there will be liver involvement, kidney involvement. However, the GALT enzyme levels will be normal. So at that time, this should ring a bell. We might be dealing with epimerase deficiency. In that case, increased urinary galactitol will give us an idea, because urinary galactitol will be elevated in all kinds of galactosemia. So if urinary galactitol is elevated, we can understand that this is a case of galactosemia, may not be due to GALT deficiency. Only in generalized form, we need strict management, just like classical galactosemia, that is complete restriction of dairy products. In the other forms, we may not need strict dietary management. Long-term outcomes are usually good. However, there is inadequate data related to it, because in the world there are very few cases of epimerase deficiency. However, none of them reported any chronic neurological complications or primary ovarian insufficiency. Galactokinase deficiency usually presents as bilateral cataract in the very early age. what happens? There is increased accumulation of galactitol, which causes osmotic swelling of lens and denaturation of proteins, resulting in cataract. It's due to deficiency of galactokinase. The treatment is diet restriction. Usually they have a good prognosis. So thank you. If you have any doubts, please leave in the comment box. I'll try to answer. You can email me at doc.sharath@yahoo.com. You can find me in Instagram as well as in X. Thank you once again.